This is a case report of female hyperandrogenism of postmenopausal women. So contents will be introduction, case presentation, case evaluation, and case discussion. Female hyperandrogenism is uncommon diagnosis among postmenopausal women. So let us call our patient Mrs. S, a 63-year-old female who presented with right-sided abdominal pain. And she also had recent abdominal pain, weight gain, and she was menopausal. But on examination, she also found to have high BMI, hirsutism, and acne. But there were no virilizing features to be seen. Next, so case evaluation followed biochemical evaluation, endocrinology evaluation, and imaging findings. So biochemical evaluation in her liver functions and renal functions, most of the investigations were normal except for her high total bilirubin and direct bilirubin levels. So because of her these hyperandrogenic features of hirsutism, acne, and recent weight gain, her testosterone levels were done, and it was more than 4 times of the upper reference range. But other investigations like oral dexamethasone suppression test, 17-hydroxyprogesterone level, BMA urine metanephrines were within the normal range. So because of this high testosterone level, so they had to find, this was all these, she was presented at the district general hospital level. So these basic investigations and the basic endocrine evaluations were done at the peripheral hospital level. So they wanted to find out a cause for this high testosterone level. So her basic imaging was done, CT abdomen. There they found out a right-sided adrenal tumor and as well as a cholecystitis with multiple gallbladder tumor. So her physicians that were currently at that time who were managing her thought this right adrenal tumor was the culprit for her high testosterone level. After the initial evaluation, because of the gallbladder problem as well as this adrenal tumor with high testosterone, the patient was directly sent for the surgical referral and the cholecystectomy and right adrenalectomy was done. So when the adrenal gland was sent for histology, it was revealed of adrenal cortical adenoma. So if this was the main culprit for the high testosterone secretion, we would expect the patient would have relieved from all these symptoms persisted. So this is where we see the patient. So this patient was referred to the tertiary care hospital, to the endocrinology at National Hospital, and the total testosterone levels were repeated and to be seen as very high. There we saw that FSH-LH levels were lower than what we would expect from a postmenopausal woman. Then the prolactin estradiol was also high, but prolactin normal. She has undergone the total testosterone following the dexamethasone suppression. There was only 44% suppression. So according to our reference, it could be an adrenal source. But there were like, we can't directly say is this adrenal or ovarian, and the patient has already undergone some surgeries. So the direct testosterone source could not be found. With a multidisciplinary discussion, the patient was decided to go for a combined adrenal ovarian venous sampling. The combined adrenal and ovarian venous sampling, the cortisol and estradiol is done for the cannulation purposes. So we look at the total testosterone level. And here we take a gradient. It is not a ratio, it is a gradient from one side to other side testosterone. If one side is more than other side, in nanograms per deciliter, it is 270. It can lateralize the side of the testosterone secretion. So in this patient, we took it as right-sided lateralization of ovarian hormonal secretion, testosterone secretion, as well as the gradient was high, so it was indicative of neoplastic source. So this was a combined report given by process after interventional radiology, chemical pathology, and endocrine multidiscipline team discussion. And with this report, she was referred to gynecological team. Androgen secretion was located at right ovary. With her age, she underwent total abdominal hysterectomy and bilateral oophorectomy. So when the histology was sent, the right ovary showed stromal hyperthecosis with both sides stromal hyperplasia. So the ultimate diagnosis was hyperthecosis, but she had hyperplasia as well. I would like to discuss how we are going to evaluate a patient with hyperandrogenism. So hyperandrogenism in a postmenopausal women, because postmenopausal women causes might be different from other young women. So these causes are mainly adrenal, ovarian, and other causes. Adrenal causes can be adenoma, carcinoma, and hyperplasia. And ovarian causes are ovarian hyperthecosis, tumors, and polycystic ovarian syndrome. And other causes are exogenous exposures and medications and other hormonal causes as hyperprolactinemia, Cushing's disease, and acromegaly. Investigations include like how we did in this patient, basically clinical symptoms and signs. Then we do the basic biochemical and endocrine evaluation and then go for the imaging. I would like to explain how we are going to differential diagnosis of causes in a post menopausal women. You have polycystic ovarian syndrome, non-classic CAH, and Cushing's syndrome. And in the other arm, you have tumors, ovarian and adrenal tumors, and ovarian hyperthecosis. So to differentiate these two sides, first you can see at the signs and symptoms. If the signs and symptoms are mild to moderate hirsutism with less virilized symptoms, these are two less sinister signs. And if there are severe virilizing symptoms with rapidly onset symptoms with clitoromegaly, deepening of voice like symptoms, they are more towards more sinister side. So then we will obviously go for testosterone levels. So they have, this is in nanomoles. If testosterone levels are comparatively low, less than 5, it is towards this less severe causes. But if it is very high, it is in tumor causes. But ovarian hyperthecosis also come to this category. So then we will go for more focused investigations for the causes and imaging. So like non-classic CAH, we would obviously go for 17-OHP, ACTH stimulation test and genetic testing. And for Cushing syndrome, we would go for 24-hour urine cortisol or ODST, dexamethasone suppression test and cause investigations. And polycystic ovarian syndrome, Rotterdam criteria. And in tumors, we will go for imaging studies. And hyperthecosis, if there are imaging studies negative, can think of hyperthecosis. So in these cases, it is good to go for AOVS like combined investigations where the hormonal and imaging investigations are combined to get a proper diagnosis in some cases. But ultimately, it will be a histological diagnosis. Polycystic ovarian syndrome is the most prevalent one. Ovarian hyperthecosis is the second prevalent. So, low testosterone levels will suggest polycystic ovarian Cushing-like syndromes, and high testosterone levels would suggest hyperthecosis and tumors. And there are other hormonal investigations that would help in diagnosis of tumors depending on the site they are secreted. A dexamethasone suppression test was done in this patient. The principle is dexamethasone would suppress the HPA axis. So depending on the suppression level, we could see if this is these androgens are secreted from ovary or adrenal. So a little bit about combined adrenal ovarian venous sampling. So adrenal to peripheral cortisol ratio, it is used to see the cannulation success in adrenal veins, and ovarian to peripheral estradiol ratio is used to assess the success of cannulation of ovarian veins. And adrenal gland total testosterone gradient or ovaries to total testosterone gradient. That is what I was telling about the gradient. So any when gradient is more than 270 nanogram per deciliter or in nanomoles more than 9.5 suggest neoplastic source, and it will help to lateralize the lesion. Ovarian hyperthecosis is a rare disorder, but there is a slow progress and cause severe virilization. It is the second most common cause of hyperandrogenism in a postmenopausal women. It is caused by luteinized Zika cells in ovarian stroma. These luteinized Zika cells will cause high amount of testosterone, but there will not be elevated other androgens. It is a special feature. So etiology, there is a genetic predisposition as well as association with polycystic ovarian syndrome. There are hypotheses like two-cell hypothesis, increased gonadotrophin stimulation causing this high testosterone, insulin resistance and hyperinsulinemia induced stromal luteinization, and these are the causes, etiologies that think ovarian hyperthecosis is caused by. Management of ovarian hyperthecosis is basically surgery by bilateral oophorectomy. When there is surgery is cannot be done, GnRH analogs can be used, and then the symptomatic management for hyperandrogenic patients with lifestyle changes, anti-androgenous spironolactone and local or tropical treatments. In summary, hyperandrogenism in postmenopausal women is rare. Clinical, biochemical, and imaging evaluation is mandatory in differential diagnosis and management. Sinister causes like tumors need to be excluded. Management includes surgery and symptomatic management. These are my references. So I want to thank my supervisor, Dr. Gaya Katulanda, endocrinology team at National Hospital, chemical pathology team at National Hospital, and Young Scientist Task Force, and Dr. Udara, and my family and parents.